two participants. Because of shortage of time, we have to start straight away. Okay, what I'm going to do is share screen with you all. Wait. Uh, okay, I need to. Okay. Okay. And I'm going to make this small so that I can see. Now I can't see you all. I can see my slides only. Okay. What we are going to do today is we will talk on feedback on assignment and some case discussion, feedback on tutorial session if you got any feedback. And if we have time, we will do the movement disorder. Okay. Some of the general comments for your assignment is you need to write your name, your IC, your place of practice, town and state. This is so that I know when you write your assignment, especially remember assignment one, I told you to write your own case, so I know where you are coming from. I'm very happy to report that for this batch, I find that most of the assignments are well written. Also, there's no more punctuation mistakes, no more spelling mistakes, no more grammar mistakes. I don't know whether you are using AI or computer assisted thing to help you, but you can continue to do that if it will help you in writing better English with no spelling mistakes and all that. Okay. There's only I haven't done all the correction of the assignments and all that, but I came across one where, although I asked for only three references, the person gave four. And out of the four, two of them are similar. So I don't know what happened, but it's very important that because these assignments all carry mark, make sure that before you submit it, make sure you check properly, you adhere to all the instruction so that you can get as much marks as possible. Okay. Some of you didn't give the Vancouver style for reference and no access date or the website. Another important general thing is you need to read the clinical scenario very carefully and also the answer to the question. Okay. I will show you example of what I mean by that. This time there wasn't very much copy and paste. But a few people still did not use their own words. It will be better for you to use your own words, which means you understand what you are writing. Okay. So this is the Vancouver style, some example. I need you to also tell me the website and when you went in, because I find that some of the references were old, outdated and all that. So try to give the best CPG or write up or best reference. Okay, for assignment 2, I only gave 2 questions and I said no more than 3 relevant references. So this was the history, the scenario. It's a young girl, primary gravida, 21 years. I put there no significant personal or family history. Yet some people want to, in their management, they want to go back to taking history. Okay, so it's already written no significant personal or family history. So they wanted to take history of thyroid disease, which wasn't necessary because it's written there already. And presents at 10 weeks of gestation with headache and with nausea and vomiting for 2 weeks, which means that this nausea and vomiting start at 8 weeks of gestation because already 2 weeks. Okay. I think some people didn't know. They thought it's 10 weeks started and then now 12 weeks. So get your timeline correct. So started at 8 weeks, nausea and vomiting, present at 10 weeks with more nausea and vomiting. Okay. So on examination, it's written here, she has got coated tongue and dry oral mucosa. So she has got some dehydration, but her eyes are not sunken. So which means that it is not severe dehydration, probably moderate dehydration due to the vomiting. So in addition, she got features of hyperthyroidism as shown in the fine tremors and tachycardia, and also fine tremors and tachycardia, okay, and also the anxious looking, okay, but she has no goiter, no eye signs, and no limb adenopathy. The rest of the systems were normal. Okay, investigations confirm the sinus tachycardia and show that urine analysis show ketonuria 3+. Hemoglobin is still okay, 11, but she has no diabetes. Okay, electrolytes, the sodium is a little bit down, probably due to the vomiting. You can see that the TSH is low, the T4 is high. But the FT3 is only slightly raised compared to the FT4, which is a lot more raised. Okay. Ultrasound shows that she has got twin pregnancy and they are now have normal growth parameters. That means they are growing normally. So the answer for what she is having is she's having gestational transient thyrotoxicosis. Most of you have got it correct, okay? But if I ask you to write the answer in full, it would be good if you write there is a primary gravida with GTT, twin pregnancy, moderate dehydration due to hyperemesis gravidarum. In fact, some of you wanted to quantify the severity of hyperemesis using the modified pregnancy-induced quantification of emesis, which is also good. That means you have looked up this particular CPG. Hyperemesis gravidarum CPG is available from the Ministry of Health. Thyroid disease is also available in the CPG. There should be an update, but so far we haven't got the update, so use the last one. And giving reasons for your answer is she has symptoms and signs of hyperthyroidism, which is what is written all here. Weight loss, 10 kilo, and sinus tachycardia, raised FT4 and low TSH. Okay. The absence of a goiter means that she probably does not have toxic adenoma or multinodular goiter. In Graves' disease, you can have a goiter also, but some Graves' disease do not have goiter. Okay. She's not Graves' disease because she got no eye signs, no acropathy, and no pre-tibial myxedema, and no family history or personal history. So not likely to be dead. The goiter also, if there's present, you have to think of toxic adenoma, multinodular goiter. She doesn't have limb adenopathy, so it's unlikely she has a malignancy. Nowadays, even young people, in pregnancy can have breast CA. Recently, I attended a conference where they say that they thought the woman was having mastitis, but actually it was a CA. So they were treating the mastitis until it was quite late. By the time they diagnosed CA, the patient was already had metastasis, already has lymph node involvement. So in GTT, the T3, as I said, is only normal or slightly elevated compared to the T4, which is more elevated than the T3. If the T3 is elevated a lot, think about Graves. And one of the ways that you can, if you worry that it could be Graves, you could do a TRAB test. Okay, TSH receptor antibody, in short, TRAB test, to see whether it could be Graves' disease. Because sometimes it may be very hard to distinguish. But in this particular case that I'm giving you, is most likely GTT. Okay. Also, in a twin pregnancy, you are more likely to get both hyperemesis gravidarum and also GTT because of the increased HCG. Okay. The next question asks for holistic management because the patient in primary care, because the patient refused to be admitted. So a few of you still write admit to hospital and all that, but we already told you that although this case is a case that requires admission, patient just refused to go hospital for whatever reason. So if you were to manage this patient in the primary care, how will you do it? So the first thing, of course, you would have to explain that what is GTT, and that it is not due to thyrotoxicosis of other conditions like Graves' disease. And this kind of GTT is only confined to the first and somewhere mid-second trimester. It should be cleared up by 18 weeks of gestation when your HCG declines. The other thing is it is not associated with any adverse maternal or fetal outcome, but it can still cause preterm labor, preeclampsia, and low birth weight. So need to follow up quite constantly. In this particular case, we don't give anti-thyroid drugs, okay? Because of the short course of the disease and the spontaneous remission, we don't give anti-thyroid drugs. Anti-thyroid drugs can cross blood-brain placenta barrier and cause fetal hypothyroidism and also birth defects, especially if given early in pregnancy. But in very severe GTT, or where you suspect that the GTT is complicated by a Graves' disease, you will have to give ATD and anti-thyroid drugs, okay? Because then the risks outweigh the benefits, okay? So you have to see whether, in which case you will have to refer to the endocrinologist, okay? You find that the patient is very, very severe, you have to refer endocrinologist. Okay. The management of GTT, if you are doing it in your primary care center, you probably have to first give her an injection to stop the vomiting. And the injection can be IV metoclopramide, but this is second-line treatment because it can sometimes give you extra pyramidal effects. So the CPG would like you all to give promethazine 12 to 25 milligram IV or IM as first line. And This patient will have to be on IV fluids as well. Beta blockers can be given for tachycardia and tremors, but you try to give the lowest therapeutic dose and the shortest required duration to minimize the potential risk for fetal growth restriction. You can give propranolol 40 milligram BD for a short period. Okay. And the IV fluids you can give even in the clinic. Okay. The IV fluids must be normal saline. Too rapid administration of the IV fluids and too much of the normal saline can result in a very terrible condition called central pontine myelinolysis, where the patient can die. I noticed that one candidate wrote that he wants to give 2 liters, which is 4 pints of normal saline in 2 hours. That is excessive. Okay. Very, very excessive. Normally we give 1 or 2 pints, which means 1 liter. And the first one maybe within a faster period, the second one over a longer period. And once a patient is no longer vomiting, we can send her back with the other medication and with oral and emetics, anti-emetics. Let me drink some water first. Excuse me a lot. Sorry for the interruption. Can you all still hear me?
Yes.
Hello? Can still see the screen, Okay. Okay. So remember, don't give dextrose infusion because dextrose infusion can give you a condition called Wernicke's encephalopathy. Okay. So just remember, give IV normal saline. When you discharge them, you can if they can drink already, you can discharge them with ORS because that will replace some of the lost electrolytes. You would probably have to see them every day, okay, until they get better, okay? Fluid replacement can be tailored to ketonuria electrolytes and discontinued once normalized and a normal diet has resumed, okay? You can consider correcting for other electrolyte imbalance, but once if they can eat already without vomiting, the electrolyte imbalance will correct itself. For such cases, you have to do serial ultrasound with Doppler scan, at least performed monthly to monitor whether the fetus is growing properly. And you have to refer to a gynecologist and an endocrinologist for shared decision making. And also do a 2 to 4 weekly thyroid function test. Okay. You cannot wait 4 to 6 weekly, 2 to 4 weekly. Any questions about the case assignment 2? Okay, assignment 1 is based on your own write-up. So it depends on how you write it up. Okay, we'll go through some cases for discussion. Can you read the case? And I want some feedback from you all on what could be the possible diagnosis. Patient presenting with fits at school. Anybody want to tell me the correct answer? It's all right to be wrong. It's okay. Edwina, would you like to comment on what could be the possible condition?
Good evening,
Edwina?
Prof. Yes, Prof.
Yeah.
Um,
Sorry, I've given you the answer already because I was trying to get some names of the. Yeah. What is your answer, Edwina?
uh, sorry, I think we need to rule out for it's likely an infection.
Uh-huh.
Um, we need to rule out likely could be a meningitis.
Yeah. But the things against meningitis is he doesn't have meningism, no neck stiffness and all that. Only he's got a high temperature, neurologically intact, but he's got seizures.
Maybe a brain abscess.
Yeah, he's got a brain
Possibility.
abscess. The clue is recurrent ear infections, okay, and ear discharge. So this is a case of cerebral abscess, okay, brain abscess because of infection from the ear. The infection can come from the sinus and even from the teeth, okay. So patients usually present with fever, headache, and seizures, okay. What is the next step of management? This one you need to admit to hospital with a neurologist for further management. And you can use a CT brain scan to confirm a cerebral abscess. Okay, what about this? Anybody wants to shout out the answer? Otherwise, I have to call out some names. Olympus. Olympus is your real name. Olympus, are you there? Lai Si Chi? Rauda? Shangita? Li
Hi,
Chi
Prof.
Seng?
Hi, Prof.
Okay.
Lai here. Exogenous steroid use
Yep. Why do you say you are correct, but why do you say that?
because of the adrenal atrophy.
Correct. Because of the adrenal atrophy. Okay. I show you the answer. Okay. Because if they are taking the exogenous steroid, this gives a negative feedback to the pituitary to tell the pituitary to reduce or stop ACTH production. The ACTH is supposed to go to stimulate the adrenal cortex to adrenals to produce the cortisol, okay? So since there is a negative feedback, the adrenals will atrophy. So the answer is exogenous steroid use. Because sometimes patients will not tell you that they are taking steroids from outside, or they may not even know. Because sometimes even if they are given things like supplements lah, holy water lah, whatever, it could be containing steroids that they do not know. Especially traditional medicine may have steroids. Even from creams and ointment also can contain steroids. Okay, next. Okay, this one. Let me see whether I've missed out. No. Okay, this one. Tennyson, you would like to give
Hello,
an
Prof.
answer?
Hi, Prof.
Yeah, you like to give an answer for this?
I think it's the answer is donkey. PFO.
The answer is PFO. Yes, correct. You are correct. The answer is PFO. Okay. There is an association between PFO, patent foramen ovale, and people with classical migraine. Classical migraine meaning a migraine that is preceded by an aura. I think classical migraine is very rare. But in case you have any patients with classical migraine with aura, maybe you might want to refer them to the cardiologist to rule out patent foramen ovale. In patients with classical migraine, they have a higher chance of getting stroke. And so you would not give them any OCP, oral contraceptive pill, because that will be contraindicated. Okay. So due to the abnormal flow of the blood in patent foramen ovale, you can have less blood going up to the brain. And this less blood going up to the brain can also trigger migraine. So there is a relationship between the two of them. Okay, this one. This will be the classical type of meningococcal meningitis. Okay, so what is the appropriate management? Who wants to? Vijaya. Malini?
A, Doctor, intravenous ceftriaxone.
Yep, correct. That will be the correct answer. Okay, because this is classic meningococcal septicemia, fever with a rash that is non-blanching and neck stiffness. And this patient is in a new environment in the university. Usually you get this kind of meningococcal meningitis when the like students going to boarding school and all that, the chances are higher, or like going to Hajj, something like that. That's why for Hajj, they force you to take a meningococcal vaccine. They force you to take meningitis vaccine. So the immediate antibiotic will be either IV ceftriaxone or cefotaxime. Okay. Now we go to the next one. And the antibiotic should be given from primary care even before you transfer to the hospital. But unfortunately, I think IM ceftriaxone is not easily available in the clinic kesihatan. Am I right? Am I right that the clinic kesihatan doesn't have ceftriaxone injections? Or do they give you all some? Hello? Those in the clinic kesihatan, have you come across injection ceftriaxone? Oh yeah, you have. You should have. I think you have. I don't know about the GP, and I think the GP should have, because there is a treatment for gonorrhea. So you all should have that injection. If I'm not mistaken, yeah, you all should have. Okay. It should be injected even in primary care if you have all the classical signs of rash, neck stiffness, high fever, and patient may or may not complain of headache. Okay, so you should give that injection. Okay, the next one. This is a little bit more difficult. First, you have to diagnose the case, then you have to see what is the treatment. TB Kwok.
Hi, yes, Prof.
Yeah, would you like to suggest an answer?
Depression. E, intravenous saline.
Okay, why do you say that? What is the
Because
what is the patient suffering from the history given?
reduced skin turgor, sunken eyes.
So
to
he has
replace,
got depression. Dehydration.
yes.
Okay.
So need to replace the fluid first.
Okay, but in addition to that, what other disease has he got?
Uh, then hypercalcemia.
Yeah. So what disease do you think he has?
Multiple myeloma.
Yep. Most likely he has multiple myeloma and causing hypercalcemia. So the hypercalcemia, let me show you in the next slide. The hypercalcemia will give you the depression, the dehydration, the bone and abdominal pain. Okay, so the first treatment is intravenous saline to rehydrate as well as stabilize the effects of the hypercalcemia. You have to give it over a few days, but this case would need admission, okay, for intravenous saline. Okay, what about this? This is ulcer, foot ulcer. What is the cause of the ulcer? Anybody wants to give an answer? Okay, anyway, I've given the answer already. Decubitus ulcer because she's unable to move her left leg. And there's also decreased perfusion, ischemia, and breakdown of tissue. Okay. Let's go on to the next question. Next question, Sharath, would you like to attempt? Sharath Raj.
Hi, doctor.
Yeah.
I would say, give me a moment.
Uh,
I'll go with cauda equina syndrome.
why do you say that?
He has anuria and bowel opening. No NBO, no bowel opening.
Yeah,
Post
yeah. So very, very important to when you have a patient with backache or unable to walk, you have to make sure that the patient doesn't have cauda equina syndrome, because it will be irreversible if the decompression is done late. And so in such cases, you always have to check for whether they can urinate, whether they have opened their bowels, and physical examination, you have to check for rectal tone as well as saddle anesthesia. Okay. So it is it's an orthopedic emergency, cauda equina syndrome. Okay, this one. Let's get a girl to answer. Siti Norashikin.
Hi, Prof. My answer is D, hypothyroidism.
Why do you say it's hypothyroidism?
Depends on the symptom, lost for appetite and not finish her meal.
Yep. Okay, and she's putting on weight. Okay. There is a relationship between endocrine disease and depression or anxiety. Okay. So if you go and look through all the endocrine disease, the thyroidism, thyroid, acromegaly, hypothyroid, you will find that there's quite a association for them to become either anxious or depressed. Okay, so you are correct. Let me see. The causes of hypothyroidism in a postpartum woman could be postpartum thyroiditis, but it could also be Hashimoto thyroiditis. Nowadays, very few people have iodine deficiency because our water is iodinated. Okay. Although if you are living in the jungle with no pipe water, you may still have iodine deficiency. Okay. This one, Shomana question. Shomana, are you there? Parimala? Parimala, are you there?
Yes, doctor, I'm here.
What do you think this woman, what disease is she having?
Clothes tied around her waist. Probably Cushing's disease.
Cushing syndrome.
Cushing's
Remember,
syndrome.
last time I told you Cushing disease is very specific.
Correct. Sorry.
It's a pituitary disease, okay? So Cushing syndrome is the umbrella that will cover all this. So if you think that she's Cushing syndrome, what would be the appropriate initial investigation?
E, urinary free cortisol measurement.
Correct. So this will be the answer. Okay, 24-hour urinary free cortisol. You must get at least about if it's high the first time, then you're all right. Otherwise, you may have to get 2 samples, and it must go up 3 to 4 times the upper limit of normal. Then only you say it's Cushing syndrome. After that, then you have to find whether it is pituitary or exogenous or whatever. Okay, the first step is 24-hour urinary free cortisol. Okay, this one, let's get another person to answer. Sui Ya Wen. Sui Ya Wen. Malini. For Malini, I think I call you already. Oops. Every time I give you all the answer.
Prof, Malini here.
Oh,
Yeah.
Malini.
Yes,
Okay. What is your answer?
C, Prof.
Okay, acromegaly. Okay, you are right. Acromegaly is because of his increasingly tired, feeling. The most important is the coarse facial features lah. I think this is the most important sign you look out for. Okay, the other things is they can have sleep apnea, they can sweat and all that. Okay, they will have large hands and feet. The facial thing is the one that is most noticeable. They have a protruding jaw and 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 also, and they got big nose, big organs everywhere, heart, lungs, everything all big. And they have carpal tunnel also. They could be hirsute, hypertension, diabetes, and heart failure. The test for them is the IGF-1, which is the insulin-like growth factor 1 test. It's not the growth hormone test, it's the IGF-1. If you go to the MEMS Society, which is Metabolic Malaysia and Endocrine and Metabolic Society, you can find some of their books. And one of them is the Practical Guide to Endocrine Dynamic Test. The other one is the 14 Acromegaly Consensus, which tells you how they do the test. So the IGF-1 must be 1.3 times higher than the upper limit of normal. Okay. And it goes according to the age. So if you are not sure equivocal result, it can be repeated, and the growth hormone suppression test with an oral glucose tolerance test can be done to confirm if the result is equivocal. Okay. Next, is it going down? It's got stuck. It doesn't want to go down. Okay, went down too much. Okay, this one. Who wants to try this? Wait, I think you've got no time already, so I think we have to go fast, okay? So this patient has got a fit problem and raised painless lesions on the front of her shin. So the raised painless lesions is the pretibial myxedema. So what she's having is Graves' disease, okay? Graves' disease, okay? The eye problem is due to the exophthalmos and also causing the extraocular muscle to have gaze problem. Okay. Clubbing is called they have clubbing and other signs in the fingers, and it's called thyroid acropathy. Okay. This one, 29-year-old man with polyuria and polydipsia. No no urinary tract infection. He says no difficulty voiding, no hesitancy, no blood in the urine, but the urine is very dilute. He has not lost any weight and he still takes a good diet. So what do you think is the most likely diagnosis in this patient? First, we know the most likely diagnosis, then we know the most appropriate investigation. So who wants to try?
Prof, I think he's
The
suffering
diagnosis
from
first. Huh?
psychogenic polydipsia.
Yep. He has got psychogenic polydipsia, in which case, what is the test you do?
Prof, water
Water
deprivation test.
deprivation test. Yep. This is the answer. Water deprivation test. Psychogenic polydipsia means there's actually nothing wrong. Just because he keep on drinking a lot of water, which some people do, they will pee out a lot of water, but the urine will be dilute lah. Okay. For this water deprivation test, he has to be admitted to the hospital to do, because can have side effects if you are not careful. Okay. So have to be admitted. Okay, this one. Who wants to attempt? Ahmad, you want to attempt this case? The important thing here is he's got olfactory sensory loss. Okay. The olfactory nerve has a problem with hypogonadism in a male. The answer is common syndrome. Okay. So some of these things are rare. You will never see in your life, but they are exam cases. Okay. So read up about it. Okay. They have hypogonadism, infertility, and problems with pubertal maturation. Okay. The differential diagnosis is idiopathic hypogonadotrophic hypogonadism. But in common syndrome, they cannot smell, hypoanosmia. Okay. It's very rare, but exam case. Okay, this one. This one is very, very easy lah. When you have painful and tender goiter, you have to think of an inflammation. So the answer will be thyroiditis. Okay. Decuven thyroiditis. Read about it. Okay. When they have decuven, the disease is caused by a viral infection. So they have fever and painful neck with signs of hyperthyroidism like tachycardia, raised ESR. And this type of patient will go through hyperthyroidism, then hypothyroidism, okay, before becoming euthyroid again. So they go through different phases. Okay, this one. It's a patient with hyperpigmentation, mouth and palms, and also has got postural hypotension when she gets up from a seated position to a standing position. This is quite hard to diagnose. It's actually Addison's disease. Okay. In Addison's disease, the adrenal gland is the opposite of Cushing syndrome, where the adrenal gland is destroyed by infection. In Malaysia, it will be TB, or it could be an autoimmune disease also. Because of the reduced cortisol, aldosterone, and sex steroid, they get postural hypotension, increased pigmentation, and they also have things like weight loss, malaise, postural hypotension, and vitiligo. Okay, this one. This one is also rare, but it's also an exam kind of case, so you need to know. The answer is motor neuron disease, because there is a combination of upper and lower motor neuron lesions. Okay. Sometimes you can have bulbar signs in the face, tongue wasting, fasciculation. Okay. I don't think I've ever seen a motor neuron disease, but it's something that you need to know for exams and also in case you ever come across one. This is the pre-TB mixing. Okay. I have never seen one except in pictures. So that's why I put the pictures for you all to see. Okay. The usual one that we find in Graves' disease is the eye sign. Even the acropathy, I have not seen one. Pre-tibial myxedema, also I have not seen one. The exophthalmos, yes. Okay. So this is non-pitting and it is yellowish to brown. It may be in papules and it's still supposed to be due to hyaluronic acid in the dermis. The treatment is high potency steroids and intralesional steroids, which we won't give also. If they have this problem and they are worried about their beauty, refer them to the dermatologist. Okay, this one. So it's a woman with confusion and hallucination after a fall from bed. If you bring her to a BOMO, the BOMO will say a ghost under the bed is kacauing her. Anybody want to say what could be the most likely diagnosis? Anyone want to give an answer? Dalila? Nurul Fatin?
Yes, Prof.
Who is that?
Dalila here.
Okay, what is the most likely diagnosis?
Probably subdural hematoma.
Very good. It's a subdural hematoma. Okay, due to the fall. Okay, but sometimes it can come days and months later. Okay, and the symptoms will be headache, increasing drowsiness, and confusion. Something that you mustn't miss also. Okay, this one, we are very familiar with eye problem, the lateral LR6, lateral rectus 6 nerve palsy. But this one is another eye problem. I don't think you have seen one, or either haven't seen one or missed one. This mother brings in a very cute little girl who looks normal, but the mother says she likes to keep her head tilted to one side, to the left side. Okay. When you force her head to be tilted to the opposite side, problem do you see? Here, the first photo, her eye is normal. When she tilts her head, the eye is normal. But when you force her to tilt the head the other way around, what do you see? Anybody? What do you see in the eye? Who is Olympus? Olympus, would you like to give a answer?
I think this is involving the cranial nerve, probably the what do you call cranial nerve 4, because the eyes.
Which cranial nerve?
Not mistaken, this is 4 because it's involving upward gaze of the right eye. Just when the trochlea.
Yeah. The right eye you see is looking up, move up, okay? So there are actually for eye muscle, it's quite easy. The mnemonic, if you remember, LR6, which is lateral rectus 6th nerve, SO4, superior oblique 4th nerve, and the rest are all the 3rd nerve, okay? So LR6, SO4. So lateral rectus, you have seen it is in the module, okay? So you know what is the lateral rectus. This one is a superior oblique muscle, okay? Superior oblique muscle, which is by the trochlear nerve or the 4th cranial nerve. It can be congenital, it can be acquired. In this case, it's congenital. So the superior oblique muscle, main job is to move the eye downwards, okay? So when there is paralysis, it cannot move the eye downwards. It will move up like this, okay? The weakness causes vertical deviation of the eye upwards, okay? So she likes to keep her head tilted to the left to compensate. But this kind of cases, you need to detect and refer them for surgery, preferably as early as possible, from 6 months, or else they will get amblyopia. That means they can only see with one eye. Okay. Ocular nerve palsy can also occur in a traumatic case like accident and all that in adults. So you can have it in adults. So next time, look out for it. Okay, any questions so far? If no questions, I'm going to show you some movement disorder. And okay, look at this movement disorder. In the interest of time, I better give you the answer.
The next gait is the spasticdiplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position in this particular gait is there's flexion at the hips, flexion at the knees, and the feet or the ankles are extended and internally rotated. And was also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides of both lower extremities. You can hear a different pattern than the paretic gait. But this is not all. The upper extremities are also involved. Again, not as much as the hemiparetic gait, but for the upper extremities, the extremity is carried in a low guard or mid guard position in the upper extremity. So this would be the type of posture and type of position that one would see for the spastic diplegic.
So this kind of cases you see in cerebral palsy. I'll give you the next case.
This gait is a myopathic.
Wait now.
This gait is a myopathic gait.
Come, it gives me straight away into the answer.
This gait is a myopathic gait. With myopathies, usually we have weakness in the pelvic girdle region, And as I walk, if I can't stabilize my pelvis, then what ends up happening is that for the weight-bearing leg, I'm trying to stabilize the hip, and I'm coming off with the other, the pelvis will then dip or drop towards the non-bearing extremity. Now, if I continue in this attitude, I'll fall. In order to compensate for that, I'm going to shift my weight, and I'm going to try to put it over the weight-bearing leg. And so I'm going to actually swing the body towards weight-bearing leg and trying to get hypermordotic and lock back over the hip that's stabilizing or is actually supporting the weight. So what will this happen is that there will be a waddle as the pelvis will actually drop, come back up, drop on the other side, and go back and forth instead of being nice and perpendicular to where it should be to the leg. So again, this is what it would look like if I'm going to walk. As I take this step, the pelvis will drop. I'll shift this way, and then as I come through, I'll shift this way. The pelvis will drop on the opposite side, and there will be a waddle. I'm in a hyperlordotic position, trying to maintain my balance. Okay. So the pelvis drops, shifting to the opposite side.
Okay, this is the waddling gait. This one is very easy. Okay.
This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait. Have a posture in which you'll be stooped over, leaning forward, and then we'll have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting in the marche petit pas.
Okay. The last gait.
Last gait, the ataxic gait, the patient has difficulty narrowing the station, maintaining balance. So typically they'll have a wide stance, trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior posterior to have a tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Now, of course, one problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, and then try to walk tandem, then I'm going to have difficulty walking.
Students, did you all have any problems with the module? Anybody has any questions or any problems with the module? Hello? Okay, if you have no problems, we have come to the end of our tutorial today. And I hope at least you all learn some new things, as well as try and read up on some things that are not very common but are important, okay? Because you will come out for exam. The common things, of course, you all must know, lah, okay? Any other things that you want to ask? Now will be a good time to ask.
Hi, Prof.
Yeah.
I want to ask what the difference between psychogenic polydipsia and diabetes insipidus?
Oh,
From the previous question.
okay. Let me tell you the difference with let me go to another wait, I stop share first. I stopped sharing already. I have to make yours small so that I can escape first. I can't escape. I need to get back to my computer. Wait, let me see whether I can make small and get back to my computer. Oh, I can't get back to my computer. Sorry, I can't get back to my computer. I took out the answer because it was too long. It is something to do with you see, there are two kinds of diabetes insipidus. Yeah, I can't get out. Let me see how can I ensure. Let me see whether ensure work or not. Okay. Okay, ensure. Okay. Hang on. Am I still with you? Hang on. Let me get back to my computer. Okay. Okay. In diabetes insipidus, the serum osmolality is elevated with no compensatory concentration of urine osmolality. So there are two kinds of diabetes insipidus. One is due to cranial, okay, and the other one is due to the nephrogenic. And the hormone involved is the antidiuretic hormone. So in cranial, the cranial one, the antidiuretic hormone is because of trauma or some other reason, is not produced. So the patient cannot concentrate the urine, okay? Cannot concentrate the urine, and so pass out a lot of urine, and so need to drink a lot of what do you call it? A lot of water, okay? In nephrogenic diabetes insipidus, they produce the antidiuretic hormone, but the kidneys are not responsive to that. Okay, so it's due to the kidneys being not responsive. Again, the same problem. So they cannot concentrate urine, they have polyuria. And if you have polyuria, you have polydipsia. Okay. So when they do the water deprivation test, they check for serum and urine osmolality. Okay. In psychogenic polydipsia, the serum osmolality will remain within the normal range, but the urine osmolality will rise to more than 600 milliosmol per kilogram as water is reabsorbed. Okay. This is when you don't give them water to drink. Okay, the water deprivation test. But if it's a diabetes insipidus, the serum osmolality is elevated, but there cannot be any compensatory concentration of urine osmolality because there is no effective antidiuretic hormone. So that's how you distinguish, okay? And the other thing is, after that, after you say that this is a diabetes insipidus, you will have to do an MRI scan of the pituitary, okay, to see whether it's a pituitary tumor or whether if the pituitary has no problem, then you think of a nephrogenic cause. Okay. So there are two different things. So have you got the answer? Hello, have you got the answer?
Yes, Prof. Thank you.
But I think you should read up about it because it's quite complicated. Okay, read up about it. So that test is actually to distinguish whether it is just habitual drinking of too much water or whether there is a diabetes insipidus cause. Okay. Yep. Should read about it. Okay. If there's nothing else, we will end it at 10:45 today. Okay. So read some of these not so common things. Also read about diabetes, type 1 diabetes. But type 1 diabetes, I think, is covered under diabetes. So that's why I didn't cover. But it's also important to know. Okay, then. No other questions. We will say goodbye and good luck to you for your exams. Okay, bye-bye.